I would like to take some time to introduce our speaker, Dr. Uche Blackstock. Our keynote speaker, Dr. Uche Blackstock, is a thought leader and sought-after speaker on health inequities and racism in healthcare. She is the founder and CEO of Advancing Health Equity, which partners with healthcare and healthcare-related organizations to address the critical factors contributing to health inequity through talks, workshops, and consulting services. She was formerly an associate professor in the Department of Emergency Medicine and the faculty director for Recruitment, Retention, and Inclusion in the Office of Diversity at NYU School of Medicine. She left NYU School of Medicine in December 2019 after almost 10 years on faculty to focus on advancing health equity. Dr. Blackstock received both her undergraduate and medical degrees from Harvard University. Dr. Blackstock, you may now have the floor.
Thank you. Thank you so much, Angelina, for that intro. I'm excited to finally be here. My schedule didn't work out for last year, so I'm glad that we could get this on the books. Just give me a few seconds to pull up my slides. Just to let everyone know, I would love to engage with you during the talk. So if you could drop comments in the chat, I will try to keep track of them. And so I'm hoping that after today's talk, everyone will be motivated to mobilize for health equity. So I always start my talks by telling people a little bit about myself. So this is a picture with my mom. Some of you may have seen this. I've shared on social media often, but this is my mom, the original Dr. Blackstock, who is holding my twin sister, Oni, and me. She was a second-year internal medicine resident at the time of this picture, was at our baptism. But she is really one of my greatest inspirations. She grew up about 15 minutes from here, where I live in Brooklyn, New York, in very different circumstances, in impoverished setting, to a single mom. She had 5 siblings and was the first person in her family to go to college. She went to Brooklyn College and had a chemistry professor there who encouraged her to apply to medical school. So she applied to medical school, ended up being accepted to all of her medical schools, and it was something that she had never really considered before. And she just needed that encouragement. And so she ended up matriculating at Harvard Med School. And after Harvard, she came back to New York City, trained at Harlem Hospital, and then came back to Brooklyn and worked for many years at Kings County Hospital, SUNY Upstate, in the same neighborhood that she grew up in, caring for her neighbors, mentoring junior faculty, and really just taught my sister and me the importance of giving back and really our obligation to help and support our communities. This is a picture of my dad with my twin sister Oni and me at our medical school graduation. And our father is an immigrant from Jamaica, came to the States when he was 18 and had a series of odd jobs. Met my mother at Brooklyn College, and then we were born. But my mother, unfortunately, is not in this picture because while we were in college, she was diagnosed with acute myelogenous leukemia, and she passed away at the age of 47. But my twin sister Oni and I, really our goal is to carry on her legacy of really a commitment to Black communities and working in service to them. I even wrote a piece about her in the Chicago Tribune in November of 2019. And really the point of the piece was to speak about the importance of a diverse healthcare workforce in terms of addressing racial health inequities. She was one of the first classes at Harvard Med School where they had enacted affirmative action policies. And so, I was very proud of her that she was able to really participate in those initiatives and contribute to Black healthcare. And then, of course, some of you may know, actually today is the anniversary of this piece that I wrote in Stat for the Boston Globe about my decision to leave NYU. And, it's interesting because I think a lot of times we feel like in academics we're on this path, and I thought I would always stay in academics. I love the stimulating environment. I love mentoring medical students, teaching residents. but it became very apparent to me, and it wasn't just at NYU. I think that it's to varying degrees at many academic medical centers that there is significant amount of racism that really prevents not only Black faculty, but trainees, Black trainees and trainees of color from really thriving in these environments. And so I thought, for me personally, it was best to lead, and I formed my organization actually 2 years ago, even before I left, Advancing Health Equity, so that I can still do this work, but I do it from the outside in the way that I want to do it, in a way that's authentic to me. So that's just a little bit about me. These are some of the objectives for today's talk, and hopefully I'll be able to get through all of them. We'll talk about some history, some federal policies that have impacted the health of communities today. We'll talk a little bit about structural competency. That is a concept that maybe some of you are already familiar with. And then we'll talk about, at the very end, some strategies. And so obviously we're at a very difficult time right now. In our country, we're in the midst of this horrible pandemic that has really devastated Black communities and other communities of color. We've seen the killings of Breonna Taylor, Ahmaud Arbery, and George Floyd. And we know that all of that is interlinked, right? We know that that racism in one institution actually influences racism in other institutions and influences the ability of communities to trust. And so this is a really great paper I recommend that you read by Dr. Steria Lang, McAlpine, and Rachel Hardiman in Minnesota. But they actually showed that in communities where there are high rates of police brutality, high rates of interaction with the police, that there are also high levels of mistrust towards medical institutions, and people are less likely to seek care. And so we already know the statistics. These are just some of the recent statistics about Black babies, Black women, and Black men in terms of mortality around pregnancy and life expectancy. I just want to give you a little bit of just historical background, especially with regards to infant mortality. So 15 years before the end of slavery, the infant mortality rate overall was quite high. Okay, many babies did not make it to their first birthday, and that was regardless of whether they were Black or white. Although, as you can see, the Black infant mortality was definitely higher than for white infants. But over time, with improvements in sanitation, with healthcare, living conditions, overall infant mortality rate improved significantly. However, as of the 1960s, of all industrialized countries, United States was still last in terms of infant mortality. And then fast forward to current day, you may notice that the overall rate has improved significantly for both Black and white babies. But if you notice, the disparity now is wider, with Black babies being more than twice as likely to die within their first year of life than white babies. So think about that, a wider disparity now, despite all of these improvements in technology, living conditions, sanitation. And there was even this piece that came out in a few months ago, also by Dr. Rachel Hardiman, who did the police mistrust study, but showing that Black babies cared for by Black doctors had improved infant mortality rates. And so, I actually want to ask the group, why would that be the case? I want you, if you can just drop in the chat, why even though this is an observational study, what are some ideas for why it would depend on what race the physician is? Okay, yeah, bias from the physicians. What else? Cultural competency, empathy, institutional racism. Right, there are probably a lot of different factors. Exactly. Patients not being heard, not listening to the mother's concerns. Physicians may not take the mother's concerns of pain seriously. Right, trust, communication, stereotyping of the provider to the physician, to the patient. Very good, thank you. And then we're also seeing these similar trends among Black women as well, that we have these really incredibly high rates of maternal mortality overall. Here in New York City, Black women are 12 times more likely to die than white women. So it really varies across the country. But our rate in the US, where Black women are 3 to 4 times more likely to die than white women, is higher than countries where, like Mexico, where nearly half the population lives in poverty. And we also know that these two women who are well known, of affluence, of means, they also talked about their own personal experiences. And so why do you think, and that's the other thing, what we're seeing is that we're seeing these disparities in maternal mortality rates, even across socioeconomic status of the mother, even across educational level. So myself, as a Black woman with a professional degree, with a medical degree, I have many more times, I'm more likely to die around pregnancy than a white woman with an 8th grade education. So what are some reasons for that? Why would Beyonce and Serena Williams also encounter these issues, even though they are of higher socioeconomic status? You can just drop that in the chat. Right, so Maria says it's clear that regardless of socioeconomic status, educational status, racism, right? Because racism, right? Because institutional racism, because interpersonal racism. Cindy says, right, because Black is Black. And yeah, there's also, someone also puts racism contributes to lack of compassion. We know that there is a racial empathy gap, right? And I think this is what happens when you live in a society that dehumanizes Black people and Black lives, right? And there's also weathering from racism. Yes, we will touch upon that briefly. And so, we've seen these trends in the COVID-19 pandemic. Sorry, also says Samantha wrote, money won't save you from racism and scientific racism, right? This idea that there are biological differences between races, that Black people are somehow different biologically. So this idea of biological essentialism. And so we've seen how the pandemic has exposed and amplified these inequities, and the rates are just getting worse and worse. This is from American Public Media Research Lab, and I recommend that you follow them. They have a Color of Coronavirus project where literally every month they update the data. I think the most recent data is 1 in 735 Black people have died from COVID-19. But even here in New York City, where I live, we saw differences in rates of COVID, right? And who was not just infected, but who was hospitalized and who was dying. And we know that this boiled down to many different factors, right? And testing criteria. For me, when I first started seeing patients in March, the CDC criteria to be tested, you actually needed to have travel to one of the countries where COVID was endemic. So at that time, it was Iran, China, Italy. And the fact was that people that I was caring for in central Brooklyn, they were not traveling to those places. So as a result, they were not being tested. So again, thinking about how bias can be embedded in criteria. We also know that testing availability varied from neighborhood to neighborhood and was less availability in Black and Brown areas. Underlying medical problems that pre-existed the pandemic due to factors related to racism, provider bias that we talked about. Here in New York City, we often found that depending on what hospital you went to for your care during the pandemic, that actually determined whether or not you lived or died. Job exposure, more likely to be working in public-facing jobs, so unable to protect yourself. When I was seeing my patients, many of them during the pandemic coming in were essential workers. They were postal workers, bus drivers, subway workers, and those were the ones who were infected. And then housing, we know that it's not just about living in a city with a dense population. We know that it's really about overcrowding, having more than one person per room in a house or apartment, and that also taking public transportation. But what ties all of this together is systemic racism. And I have to just give you a heads up, my kids are in the next room, so you may hear some shrieks, but they're with their dad, they're fine. And so just so some definitions that we all are on the same page. Health equity is, I think, what we want for all of our patients, everyone to have the ability to achieve the highest health potential. And often I think we use inequities and disparities interchangeably, and I'm guilty of that too. But I really want us to push each other to use inequities, because inequities really focuses on the fact that these differences that we're seeing are human-made, man-made, a result of policies and practices, right, that influence our social, economic, and environmental advantage and disadvantage. So if I said, as I said earlier, Black women are more likely to die around pregnancy than white women, that's an inequity. But if I said that male babies are more, way more than female babies, there is a genetic basis for that, right? And that's more of a disparity. That's not based on any particular social, economic, or environmental disadvantage. And so I know people have seen some version of this before, the difference between equality and equity. I think that too often, a colorblind approach is taken to how we care for patients. Equality is essentially giving each person the same thing without acknowledging that everyone is starting out with different access to resources, with different advantages and disadvantages. Whereas equity is accounting for those differences, accounting for the fact that we all start off with different resources, different opportunities, different exposures and experiences, and that each person should be given what they need to reach their fullest health potential, or to live their best life possible. And what justice is, in this picture, we have that fence, and that fence obviously represents a structural barrier. Health justice is when we dismantle those barriers, that there are no barriers there, where everyone really can live their best life. And so I know everyone is familiar with the social determinants of health, but I show this because I really want to bring home the fact that, that 40% of what determines how the health of a person, of a community, are socioeconomic factors. And I got this from the CDC website, really what they should also be saying, also our systems of oppression, right? Our racism, sexism, that's what influences the health of people and communities more than, I think, what we were traditionally taught in medical school, that individual behaviors dictate how someone fares in life, right? And really what we see is that actually is not as impactful. And so, what happens when we have communities where people don't have the resources to adequately care for themselves and their families, where they're under stress, they have increased allostatic load, there are changes in their cortisol level. And that, is influenced by, do they have public transportation, right? Are they able to get to their jobs, to their appointments? What is their housing status? Do they have housing insecurity? Do they have any control over their job status, about how many hours they work, and their pay? So all of that is very important. We have to think about the chronic stress that our patients have to endure as a result of these inequities. And then, also thinking about this idea of, the weathering effect of epigenetics, right? We know that race is not biologic, that it's a social construct. But epigenetics is real, right? The idea that living with chronic stress. So for example, one of the thoughts for why the infant mortality rate is so high among Black babies, one factor is thought to be actually the stress that Black mothers endured during slavery. And that affected gene expression, and that has been passed on across generations. And the thought also is with diabetes, with immune diseases, and then also we see accelerated aging and telomeres as well in Black and Latino people, again, as a result of the chronic stress of living with racism in this country. And what I will say is that there are actually some studies looking at Black immigrants from the diaspora, that when they first come to this country, the first generation, their health is great, but by the second generation, their health status has deteriorated, and very similar to Black people who have been in this country for generations. So I always say that living in this country actually makes Black people sick. And so these inequities exist for different reasons, right? We know quality of care that people receive, whether or not they're able to access. And we know that Black and Brown communities have higher rates of uninsurance and underinsurance, and then differences in life opportunities, exposures, and stresses that are related to systemic racism. I love this iceberg example because I think I'd love to ask you, I'll just drop in the chat, like, what do you think this iceberg example is showing? Like what we see on top and what we don't see on the bottom. So just drop in the chat, what do you think this iceberg is showing? Yeah, so again, individual racism exactly versus systemic. And so I think what happens often is that people, when folks think about racism, they think about interpersonal, like what you see above the water, right? Is the interpersonal calling someone a racial slur, harming someone because they're of a different race, microaggressions, right? But what you don't see, and what actually is the foundation of what racism is systemic racism. It's how practices and policies shape exposures, experiences, opportunities, even thinking about the policies around mass incarceration and how those have resulted in predominantly Black men and other men of color being incarcerated, right? So a lot of it having to do with policies. And I think that's something that's very underappreciated. I think that's, often we don't learn about that in school, and I will get into a little bit of that. So in the chat, I'm seeing Sarah says the top is what everyone thinks racism is, and the bottom is structural racism, right? Yeah, and Shane says, reminds me of Dr. Kamara Jones' Gardner's Tale and the distance between initial historic injury and the consequences. And then Jennifer says, our approach to addressing racism is often reactionary, addressing individual events that we see on the surface, exactly, instead of thinking about systemically and how in all the different social structures like education, the criminal legal system. I like to say criminal legal instead of criminal justice, because we know that often justice is not found in that system, and in the healthcare system have resulted, in poor outcomes, right? And the death penalty, executions in this political term is unethical at the very least. I agree. All right, so I'm just going to go on a little bit. Yes, and microaggressions. Yes, let's note microaggressions. That name was given in terms of the micro being from the person that's delivering it, thinking that it's not significant, as opposed to the person who's receiving it. And I, definitely have a problems with the term overall, which just call it what it is, racism. But yes, exactly. Just wanted to note that. So does anyone know who this person is on the right of the slide? You can put it in the chat. Yeah, it's FDR. And so, and FDR was responsible and really well known for the New Deal, which was a series of programs and public work projects to help Americans recover from the Great Depression. And one thing that it's known for is the creation of the Federal Housing Administration, so FHA. The FHA was responsible for the development of mass subdivisions across the country, otherwise known as what? What do you think? Mass subdivisions? I'll get to redlining, but no, the suburbs. So it was responsible for developing the suburbs and giving Americans an opportunity to buy homes in these mass subdivisions. The only problem was that within the deeds of these properties, there were clauses that said that Black people could not purchase these properties, and that even if there was a white family that wanted to resell their property in a suburb, they could not resell it to a Black person. And so this is how the suburbs started off as white, right? And that's why typically when we think about suburbs, it's less so now. But when you think about suburbs, you think about white because of these FHA policies with the New Deal that essentially discriminated against Black Americans and did not allow them to purchase property. And then also, yes, APJ is also responsible for the creation for redlining. And I have some original documents to share with you all. The University of Richmond has a great website, and they have original redlining documents from most major cities, but this is one from Portland, Oregon. And essentially, can someone just drop in the chat, like what is redlining? Right, so yeah, so redlining, banks give loans, separation of housing, access based on race. So essentially it was this idea of, and it resulted in residential segregation, of grading neighborhoods A, B, C, or D based on who lived in that neighborhood, right? And most of it was based on the race of the race and ethnicity of the people who lived in that neighborhood. If it was mostly white, that neighborhood got an A rating. And if you lived in that A neighborhood, just based on living in that A neighborhood, you were more likely to be able to qualify for a federally backed mortgage and mortgage insurance. If you lived in a lower rated neighborhood, a C or D, you were less likely to qualify just because you lived in that neighborhood. So I want to give some examples of this. So this is from a neighborhood in Portland called Gainsborough. They list the occupation, business, and professional men. They ask for, are there any foreign-born families? They use this term subversive to refer to racial and ethnic minorities. They ask about, are there any Negro people? Is there infiltration? So even thinking about the language that were used, and these are federal documents talking about Black people and other people of color. And so this neighborhood, because it was mostly white professional, got a high rating of an A-. So if you lived in this neighborhood, you could purchase property. So this is another neighborhood. This is called Lower Albina, and it's mostly laborers, artisans, Southern Europeans. They say there are many Negro infiltration continuing. Foreign-born families, about 40% Southern European and Orientals. And then they talk about in the clarifying remarks how this is a melting pot, Portland's melting pot. 3/4 of the Negro population live there, as well as 300 Orientals, 1,000 Southern Europeans, and Russians. And so this place, they got a low red grade of a D-. Okay, and so what redlining did, right? Yeah, the verbiage is awful, right? So even look how even racist, and these are federal documents. And so I'm going to get there in a little bit, but I want you to start thinking about what happens when people living in neighborhoods cannot purchase property. What is the domino effect of that? Because what I will say now is that when you look at redlined neighborhoods, although gentrification has influenced this a little bit, but formerly redlined neighborhoods in the 1930s, they correspond with almost 100 years later, neighborhoods with the worst health outcomes, with the shortest life expectancies, the highest chronic disease burdens. And I see people putting what the effects of redlining and these other policies are, and we will get there. I just want to do one other federal policy, the GI Bill. Does anyone know what the GI Bill, the point of the GI Bill was? So I'm sure you probably saw and learned a little bit about it, right? So most people think about it, right, providing financial assistance for college for returning World War II veterans, and right, and Marquita mentions housing. So a lot of people don't know that there's a housing provision, and thank you, Addie. There's a housing provision to the GI Bill where veterans were able to qualify for, again, federally backed mortgages to purchase property. The problem was that Black returning veterans wanted to purchase property in Black neighborhoods because also they weren't allowed to live in white neighborhoods. However, banks would not give them mortgages to live in Black neighborhoods. So Black returning World War II veterans were not able to take advantage of the housing provision of the GI Bill. And so what this has resulted in is this racial wealth gap. We know that owning homes in this country is the primary way to accumulate wealth. right? And so if you have policies that forbid population, certain communities from purchasing property, then this is what we have. And I always show this because I want people to understand that it's not about, you know, white people working harder than Black and Latino people. We have had federal policies that have shaped who can or cannot own property, and that impacts who can, you know, develop wealth and the transfer of wealth across generations. So again, going back to redlining, for example, why would redlining result in poor health outcomes today? So you have a neighborhood where people cannot buy property. What happens to the property values? And you can drop this in the chat, right? Property values go down. Do businesses want to come to those neighborhoods? If businesses don't want to come to those, excuse me, if businesses don't want to come to those neighborhoods, what happens to the neighborhood? Food deserts, what else? No jobs, right? Right. Environmental racism. Also, what happens to schools? Right, someone says no school taxes. We know that property taxes often go towards funding public education. So schools are underfunded, which influences the quality of education, right? Right, less infrastructure, less public transportation, right? So yeah, so it's exactly. And so what we see is that it's really, and this is not even exhaustive what I showed you, but we have federal policies that have essentially led to the disinvestment in Black communities and other communities of color that have directly impacted the health outcomes. Because remember, thinking about the social determinants of health, that it impacts housing, it impacts education, jobs, right? And so those are all the social determinants of health. And that's why we're seeing worse outcomes. And so someone mentioned this already, but how zip code is a better predictor. This is in St. Louis, and looking at the results of redlining, that even blocks apart, you have differences in home values, differences in income, differences in racially, demographically, who is living in those neighborhoods. And this is what we don't learn in medical school. I got so excited sharing with you guys and getting hoarse. Sarah says, even public services were not given to many red line districts. Yeah. And even thinking about today, there's still forms of redlining. There was predatory lending up until recently, and still goes on, where Black and Latino people are charged higher interest rates for mortgages. And so I think understanding how systemic racism has worked, so thinking about what we saw underneath the water and that iceberg, right? And this is just an example. This is just what residential segregation has done and how it's impacted health, but also thinking about more historically. And so I just want to talk about a few occurrences historically that I think need to be reconciled within the healthcare medicine sphere. I'm not going to talk about some of the ones that most people know about, like J. Marion Sims and Tuskegee, because I think you probably know about that. But I want to just mention how, actually even J. Marion Sims, thinking about how there were people who were physicians that were perpetuating, these racist notions, these ideas of biological essentialism. Does anyone know who Charles Caldwell is? Or what the image on the left shows? Yeah, it's actually phrenology, yes. And so it's this idea that the bumps and grooves on someone's head correspond to different personality characteristics. And it was actually, it's obviously been debunked as junk science. It was developed in Germany. And Charles Caldwell is a physician from Kentucky. He owned enslaved people. And he brought this idea of phrenology, and it essentially said and perpetuated this idea that African enslaved people had a bump on their head that meant that they needed to be tamed or tameable. So he essentially was using this pseudoscience to justify slavery. And so I think a lot of the harm that has been done in this country has been done by people who are revered and have been revered and respected in healthcare, like Charles Caldwell, who have perpetuated these very, very dangerous racist notions. I always want to talk about the National Negro Medical Association, now known as actually just as NMA, because we talk a lot about health inequities, and a lot of the health inequities are related to the fact that we don't have many Black physicians, healthcare workers, or other healthcare workers of color. And I want to just make sure people understand that this is almost intentional, that the American Medical Association for many, many years did not allow Black physicians to join. And then even in the early 1900s, once the national organization said, sure, we'll let them join, many local and state chapters still did not allow Black physicians. And so that's what led to the creation of the National Negro Medical Association, now known as the NMA. But also American Medical Association was responsible for the Flexner Report, and basically paid this white educator to go around to different medical schools and essentially come up with these very rigid, stringent guidelines for how medical schools should function. And that led to the closure of the majority of Black medical schools around the turn of the century. And it's estimated, there was actually a study last year that estimated that those medical schools that were forced to be closed because of the Flexner Report would have educated between 25 and 35,000 Black physicians. I'm sorry, when I hear that, and then you think about how many patients they could have cared for. So this is the history that you need to know, and thinking about how institutional racism, how it kills, and it kills in ways that may not be so apparent. Sorry. And then I also want to just bring up eugenics. Many people don't know this, but there are about 33 states from 1900s to the 1970s. So all the states that are in flat black and white on the left side of the screen that had programs that were sponsored by the state, that were responsible, who performed sterilizations on mostly women of color, women from low-income communities, women with mental illness, and often informed consent was not obtained from these women. And then just even fast forward to now, thinking about what we heard recently, I don't know the status of it, but in the ICE detention centers, right? We heard about these hysterectomies that were being performed that just, obviously, I think ties into what the history in this country of eugenics. And then I don't know if people have heard about this, but in Puerto Rico, Puerto Rico had the largest trial of oral contraceptives. And it was in the 1950s. The reason why it wasn't done in mainland is because of the political, cultural environment at the time. They knew they would not be able to get approval from the FDA. So these researchers went to Puerto Rico and they enrolled women in this study, and they did not have study coordinators who spoke Spanish. So many of these women did not realize they were being studied for a trial. They knew they were receiving some form of contraception, but they did not understand that they were part of a trial. And when I talked to some of my colleagues from Puerto Rico, they have told me that this study for them is similar to what the Tuskegee study represents for Black Americans. So again, thinking about how the healthcare system, and we talk about even today about the vaccines, right? They talk about vaccine hesitancy in Black communities and other communities of color, but it's really not about the communities. It's about how institutions have treated these communities and have proved untrustworthy. And these are some examples. And I want to say even until recently, in the late 2000s, there were 150 women who were incarcerated who were sterilized in a prison in California. So even recently, and there was even a sheriff in a town in Indiana recently who told women who were incarcerated that he would shorten their prison sentences if they agreed to be sterilized. So this still goes on, right? And we have to be aware of this. It's really incumbent upon us in caring for patients and for our communities to be aware of this information that's out there. And so I guess this is just a reflection question, and I just want you to just think about it, like think about what changes would need to happen within these institutions, within healthcare institutions, for them to feel seen, held, and appreciated. So just thinking about this, right? Thinking about what do institutions need to do, right? Because so often we think about, oh, what does the community need to do? No, what do institutions need to do to be more trustworthy, right? Given this history, and it's not just a history, it's ongoing discrimination that people face, and thinking about how can we do that systematically, right? Because it's so embedded. I just have a few other slides to share with you. I love this slide just to talk about oppression and privilege. We know that there are many different systems of oppression. I've talked about racism, sexism, homophobia, cissexism. But what this shows, these are two escalators, right? You have a down escalator on the left and a up escalator on the right. And so what happens if someone is trying to walk up a down escalator? So what happens on the left if you try to walk up that escalator? You can put it in the chat. Yeah, they don't get anywhere. And can they get to the top? Is it possible? Yeah, you can. Yeah, you have to work a lot harder to get there, right? Yeah. And then what happens on the right when you are walking up an up escalator? Or can you just stand still? You could just stand still, right, and get to the top, or you can walk and still get some assistance, right? And so, I think this is just important. I love this this picture just to illustrate the difference between oppression and privilege for people to understand that, no one says you didn't work hard, but you had significant advantages. And I tie this into those federal policies that I mentioned to you. When we look at home ownership, when we look at the racial wealth gap, it's not because Black and Latinx people didn't work hard, right? We know everyone works hard, but we know that there are policies and practices that have actually assisted people, right? That have given people wealth, and restricted wealth and held wealth back from other communities. I want to just share also this the 4 I's of oppression with you. I don't know if anyone has heard of this, but it's a good way of thinking about systems of oppression and categorizing them. And I'm actually going to show you a video that explains it much better than I do. But so the first I is ideological, right? And I think that's the foundation of any oppressive system, the idea that one group is better than another. Institutional, which we've talked about, thinking about how oppression is embedded within the institutions within our society, like the criminal legal system, like education, like healthcare. Interpersonal, which is what we talked about, where it's more obvious to see, and internalized is internalizing those impressive messages, and often that becoming in the subconscious. So I'm about to play a video. Please let me know if you don't hear it.
Oppression. It's a word that's often used as a blanket term, but there's actually a whole lot more to it. There are 4 interlocking aspects of oppression: ideological, institutional, interpersonal, and internalized. And it might seem like a small difference, but it's very important to be able to distinguish between each kind, because understanding oppression is the first step to fighting it. Let's start with the core at the heart of every form of oppression: ideology. Every system of oppression comes from the idea that one group is somehow better than another. Ideological oppression starts when the dominant group associates positive qualities with itself and negative qualities with the marginalized or othered group. Ideological oppression describes the deeply ingrained social root of inequality. It's the larger overarching idea that leads to the isms. For example, the idea that Black people are dangerous is ideological racism. The idea that poor people are lazy is ideological classism. Ideological oppression leads to institutional oppression. Institutional oppression is the way that systems and institutions manifest the dominant ideology. Institutions control access. Who is able to get to what and how? This includes legal rights, police practice, access to medical care and education, public policy, political power, and media representation. For example, when women make 2/3 of what men make, that's institutional sexism. When a building is constructed without wheelchair ramps, that's institutional ableism. All of this leads to interpersonal oppression. Interpersonal oppression is probably the easiest to recognize because it happens all around us. Interpersonal oppression is the way that people play out discrimination and violence on each other. It can take the form of microaggressions, jokes, stereotypes, and harassment. For example, when a student is bullied for being gay, it's interpersonal homophobia. When a Muslim person is told that they're a terrorist, it's interpersonal Islamophobia. And all those forces, ideological, institutional, and interpersonal, lead to internalized oppression. Internalized oppression is the way that people with marginalized identities internalize narratives of their own inferiority. It's what leads people to feel less than. This is the end goal of oppression. The oppressive party doesn't need to exert force any longer because the marginalized group is enacting oppression on itself to maintain the status quo. It's important to remember that it's never a marginalized person's fault that they feel internalized oppression. It's simply what happens when someone faces negative stereotypes, low expectations, and ongoing discrimination. So, for example, an immigrant feeling embarrassed about having an accent is internalized xenophobia. When a trans woman feels that they can never be a real woman, that's internalized transphobia. So, to review, the 4 I's of oppression are ideological, institutional, interpersonal, and internalized. Each of these types are interconnected and completely supported by the others. They can never exist on their own and can even be seen as a cycle. Now that you understand the different kinds of oppression, you're even more equipped to fight it. Don't forget that any effort to dismantle oppression should aim to address it at all 4 of these levels. Thanks for watching.
Oops, sorry, didn't mean to close that. One sec. So I'm going to do a quick quiz for you all, and I want you to put it in the chat. Let's see. Sorry. Okay, so I'm going to give you a few examples. And again, as the video explained, in any situation, there are different aspects of the 4 I's that may be working together, but I want you just to share what you think is the predominant type. Okay, so this one, this example, Black women are 3 to 4 times more likely than white women to die from pregnancy-related complication. Is that predominantly ideological, institutional, interpersonal, or internalized, right? So institutional, great. And of course, there's probably interpersonal in there as well, but yes, you get the idea. Okay, what about this one? The cultural narrative that white patients are more compliant and more likely to follow clinician instructions than Black patients and other patients of color. Good, ideological, perfect, right? Because it's this idea, this cultural narrative that one group of patients is more difficult than another. Very good. Okay, what about this one? A Black child identifying a white doll as good and a Black doll as bad. Good, internalized, exactly. It's a child taking on these oppressive messages and internalizing it. Very good. And I have one last one. Clinicians are less likely to prescribe pain medication to Black patients than white patients, and we have the data for this. What is this type, right? Interpersonal, right? Because it's actually their prescribing habits directly related to the patient. Good, okay, good, you guys got it. So just things I want you to think about is thinking about the 4 I's. You know, after this talk, like how can we use the 4 I's to help us envision change within medicine and healthcare for clinicians, our patients, and their communities. So I just want you to think about the 4 I's and how do you think that we can use it to address oppressive systems. I have a few other slides to share with you all before the Q&A. And so I know some of you are, I'm sorry, Lauren said ideological oppression recognizes the role of culture, which has been ignored in epidemiological work of this problem, which tends to stop at the social determinants, right? These determinants have cultural ideological basis. Thank you for that. And so the last concept I'm going to leave you with is I'll answer questions in the Q&A, but I'm just going to go on now. Structural competencies, and some of you probably are familiar with this idea, but it's this idea a lot of times in public health research, racism is never explicitly mentioned. People talk about the social determinants of health leading to health inequities, but what we need to think more about is upstream factors, right? So upstream factors like the social and economic policies, like the federal policies I shared with you, the GI Bill, redlining, that then impact more downstream the social determinants of health. Economic systems, the fact that we live in a capitalist society, right? That affects more downstream the social determinants of health, and social hierarchies like systemic racism. And so I challenge you to think more about how especially systemic racism can be a key driving force of the social determinants of health, which then influence the health outcomes and the inequities that we see. And I'll give you some examples. So thinking about using a structural competency model can actually help you think about how you can help or not help, but support our communities. So this is from the Structural Competency Working Group, and I really recommend that you go to their website, and you can just put it in Google, but essentially thinking about interventions at different levels. And so there's a low-hanging fruit, right? At the individual level, we often make these judgments about patients' behavior without considering the structural problems, without considering how they are made structurally vulnerable. So some strategies are talking less, listening more, using more shared decision-making with your patients, cultivating structural humility, which is this idea that as a clinician, you have a better understanding of the circumstances in which your patient lives. Interpersonal. So, often we prefer biomedical interpretations over what our patients are telling us. And there are some tools that are out there, like a structural vulnerability checklist, that can help you identify, in your patient's life, are they going through housing insecurity? Are they going through ongoing discrimination? Are they having difficulty accessing healthcare? And it's not as if you have to find the solution, but you should be able to connect them with the social services or programs that they need. And so it's this idea of thinking more outside of the four walls of the clinic room or hospital room that you're in with them, and thinking about the other social structures and forces that are at play in their lives. And then I think institutionally, often healthcare institutions have not adapted to our community needs. And I think personally, every healthcare institution should have an Office of Community Engagement. We need to really center the communities that we care for. We need to hear what their concerns and what their priorities are. And then on that same element, community, we actually have a history, as I shared, of healthcare institutions exploiting communities. And so what's really important is for our institutions to partner with community-based organizations that are already there, have been there doing the work. And these could be faith-based organizations, neighborhood coalitions, but people who are trusted leaders in the community that can really help healthcare institutions address those issues outside of a clinical setting. And then even thinking about research and policy, how can we as clinicians advocate for our patients? It could be in the kind of research that we do addressing these issues of systemic racism or around housing, job, and education policies. And so here are some examples. Does anyone know who the person on the left is in this picture? Yeah, so this is Dr. Mona Hanna Atisha, exactly. And she is a pediatrician in Flint, Michigan. And she noted that a lot of her pediatric patients' lead levels were coming back elevated. And she actually was concerned that there was lead in the water. And so she she actually first emailed her Congress people about this. No one responded. So she decided to hold a press conference. And that's how the world first knew about the Flint, Michigan water crisis. But she is an example of how, as clinicians, as physicians, we advocate for the communities that we serve. And then the Black Panthers, actually my twin sister and I just wrote a piece in the JAMA Health Forum about the Black Panthers and Young Lords, but using their models of health activism to center our communities. And I would say that the Black Panthers used or had this idea of structural competency even before it had a name. So, I mean, having free clinics throughout the country, free breakfast programs, food giveaways, having legal clinics where people could come for legal advice, offering transportations for families to see their loved ones, and then even offering sickle cell testing and doing research around sickle cell disease, which we know has been really chronically underfunded for decades. So, this is the piece that my sister and I wrote in JAMA, and thank you for sharing that, yes. And then thinking about, what does structural competent care look like in action? This is a great piece from JAMA where Jonathan Metzl, who's a psychiatrist, but he and Helena Hansen, another psychiatrist, they developed this idea of structural competency. But it looks like, during a pandemic, for healthcare centers to ensure that their patients have internet access so that they can make their telehealth visits, right? Ensuring that our patients have food and housing assistance, delivering resources like PPE to them, and then even thinking outside of the box about using medical, financial, legal partnerships to help our patients who are having labor concerns and immigration concerns. And so the idea is that we don't just care about their health. We know that these other factors, where they live, where they play, where they work, also influences the health of their communities. So I want you all just to think about what level of intervention you're going to take in this next year. I would say the individual and interpersonal are the low-hanging fruit. So I urge you to think more about what kind of community engagement are you going to be involved in, research, policy, and definitely that is what we are, I think, obligated to do as people who care for patients. So that was my reflection question for you all now. And so some of my take-home points, because I think I'm running out of time, yes, that recognize that racism, not race, is the risk factor for morbidity and mortality, that race is a social construct, and really it's the environment that racism creates that makes people sick. You think about structural competency as a framework to address these inequities, and then even more importantly, be intentional about mobilizing for health equity, right? It's action that really makes the difference. So I'm sorry I went so quickly. I had a lot of information I wanted to share with you, and so I'm happy to take a few questions.
Okay, everyone, we only have time for about 1 or 2 questions, so I'm just going to get us started. And the first question is, in a previous session, the presenter talked about the dual approach to addressing health inequities and focusing on both broad-based approaches and targeted approaches to disadvantaged communities. How can we as a public health practitioners do both with limited resources, which are largely controlled and allocated by those who do not understand or recognize racism as the root cause of these social and health inequities, and continue to perpetuate racist policies and practices?
So targeted versus, what was the other?
Targeted versus broad-based.
Yeah, no, I mean, I think it's probably similar to kind of what I laid out with the interventions. Like there are things that you can do in terms of engaging with like housing advocacy, job advocacy groups. But then there's also policy, right? We don't, if we're thinking about working within organizations, we can think about organizational practices and policies. What committees do we need to get on? How can we organize within our institutions, right, to talk to the key stakeholders and get people on board? But then I also think that we need to think about, legislative policies. So thinking about how can we improve opportunities for home ownership? How can we improve access, like working on Medicaid expansions, right? So I think that we definitely have to think about the low-hanging fruit, but thinking about how we can help on a broader level as well. And I recognize that sometimes it's very difficult within these institutions. It has been my own experience, but what I have seen in the last year is that I think there is a little bit of an awakening that we need to really slide in and get that work done.
And I think we have time for one last question. So I believe that unjust biases from older generations are continuously passed down to kids. Changing the viewpoints a person was raised with could be hard. What do you think that we can do to intervene in the transmission of these unjust biases to future generations?
Yeah, no, I think people probably learn their first biases from their family members. I think that what really needs to be done, that there's tremendous work within the education system in terms of how we are taught, what we're taught on from the perspective. And I'm not even talking about medical school. I'm talking about the K through 12 pipeline. That like there needs to be a rehaul of that. The challenge is that is the funding issues, which is again why we need to be looking at policies that improve funding to public schools. But I think education is key in how our kids are taught. I think also people get a lot of these ideas from the media. We need to hold the media accountable for how our communities are represented and talked about, thinking about who is writing the articles, who is reporting on the stories that impact our communities as well.
Thank you so much. I think that's all the time we have. We're about to end.
Well, thank you so much for having me, and thank you so much to the audience for like just being so engaging and dropping all of your comments and questions in the chat. Really, this was an honor.